Hi guys, hope you are doing great. Today let's go through the NBME 16 review. I have divided this section into three colored parts: green, orange and blue, and followed by the uncolored portion which will be discussing this later. And this is the last NBME that I am putting on this channel. Let's start with the green portion. This is a case of prinzmental angina, also known as variant angina. Recurrent chest pain at rest, especially at night, with transient ST elevation that resolves when the chest pain ends, and the troponin is normal. ST elevation disappears once the episode gets resolved. The next part is about the hematology, predominantly lymphocytes in an elderly patient. This is a classic for chronic lymphocytic leukemia. Diagnosis here is flow cytometry. It's not bone marrow biopsy. If the case is mature granulocytes with basophilia, think of CML, and the diagnosis here is cytogenetic studies, BCR ABL testing. If the case is on a peripheral smear, if we see blasts, it is classic for acute leukemia. Diagnosis here is bone marrow biopsy plus flow cytometry. We'll discuss these two combined. Whenever a diabetes question asks which medication should be added, first scan the comorbidities present in the question. If the question is about like atherosclerotic disease, try to add another drug like SGLT2 inhibitor or GLP-1 agonist. If the presentation is about heart failure or a CKD, try adding SGLT2 inhibitor. If the presentation is showing up the obesity, try adding GLP-1 agonist. If there are already two or three drugs added and still the HbA1c is like 9 or 10, try adding insulin here. Do not choose insulin merely because metformin plus another drug and the HbA1c was still elevated. Try checking these conditions and add the drug accordingly. Osgood-Schlatter disease or traction apophysitis or enthesitis. These three terms are same, one and the same, and the osteochondritis dissecans is different. Pathology here is medial femoral epicondyle, whereas the pathology here is tibial tuberosity traction apophysitis. Punctate bladder hemorrhages plus mast cells plus chronic bladder pain with urgency or frequency, and the cultures are negative. Pain related to bladder filling and relieved by voiding. Think of interstitial cystitis. Long-standing history of diabetes plus erectile ejaculatory dysfunction plus orthostatic hypotension plus decreased vibration, proprioception, and absent ankle reflexes. Think of diabetic autonomic neuropathy. This is a fresh question which I have seen this like for the first time in this NBME. Anosmia plus ipsilateral optic atrophy plus contralateral papilledema. Think of olfactory groove meningioma. This is a classic for Foster Kennedy syndrome. Hematopoietic stem cell transplantation is the definitive therapy for Wiskott-Ulrich syndrome. Sigmoid volvulus, first line of treatment is sigmoidoscopic detorsion and rectal tube placement. If there are signs of peritonitis or perforation, surgical treatment with a sigmoid resection is performed. Let's go through the blue portion. Fever, if the patient has fever, severe headache, photophobia, nuchal rigidity, this classically indicates meningitis, and neuroimaging is only required when you are having a slightest of the suspicion about focal neurological deficit or increased intracranial pressure. Then you have to do this CT scan or MRI before going through the lumbar puncture. Otherwise, you can directly proceed to the lumbar puncture. Rickettsial antibody support later. Serology may be initially negative, and this serology is not going to help you in the emergency condition. Current treatment group plus current control group. This indicates contemporaneous controls. This sequence is helpful for the better comparison, whereas current treatment group plus control group with the patients from an older study. This is a non-contemporaneous controls. This indicates like increases the major risk of bias. Why? It allows time related differences and confounding. If you see blasts on peripheral smear, and like this classically indicate for acute leukemia, try to differentiate from Gaucher disease. Bilateral breath sounds doesn't eliminate the need for intubation. Check GCS in trauma. If it is less than 8, go for intubation. SpO2 91 with 100% oxygen and GCS less than 8 is also concerning. Maintain airway and breathing first. Confound pulmonary embolism plus normal blood pressure. Start with IV heparin. Thrombolysis is reserved for a massive pulmonary embolism with hemodynamic instability. Cough during meals plus fever, focal lung crackles. Suspect aspiration pneumonia. Start with the chest X-ray workup. Worry about the mechanism of aspiration later by doing a barium swallow. Let's go through the orange portion. This is the differentiation between OCD and OCPD. When the patient says, I know this is irrational, but I cannot stop. This is classic for OCD. Patient is having like a ego dystonic feature. This is ego syntonic. My way is the correct way. The ego syntonic nature of the patient behavior, in which the patient does not recognize the problematic nature of their behaviors, distinguishes OCPD from most other anxiety disorders. I have discussed this earlier. In unilateral renal artery stenosis, the stenotic kidney increases the renin. Normal contralateral kidney suppresses the renin. And secondary hyperaldosteronism causes hypokalemia. Young sexually active female plus isolated purulent arthritis, think of disseminated gonococcal infection. E. coli decreases the urine pH. Biologics in treatment of atopic dermatitis, medications that target the interleukin pathway or dupilumab, JAK inhibitors, upadacitinib. This is a low yield to know. They won't be asking this, just try to remember once. Let's go through the uncolored portion. Recurrent overuse tendinopathy due to excessive running or training volume. What is the best preventive measure? Just decrease the weekly running distance. It's not the heel orthotics or ankle supports. Patient presents you with acute calicularis cholecystitis in a stable, is stable. Start treating empirically with the antibiotics and fluids, followed by early laparoscopic cholecystectomy within less than 72 hours during the same hospitalization. A patient presenting after intentional medication ingestion, start evaluating in the emergency department, and after stabilization shift him to the inpatient hospitalization for psychiatric evaluation. Improved FEV1 is a surrogate outcome and cannot be by itself prove that medication reduces asthma related hospitalizations. Hashimoto's can even occur at the age of 5. Previously normal child developed acquired primary hypothyroidism. It classically indicates autoimmune thyroiditis. Iodine deficiency can have goiter. WDHA syndrome, watery diarrhea, hypokalemia, achlorhydria. This is due to vasoactive intestinal peptide. VIPoma. Always consider atypical antipsychotic. Give preference to the second generation antipsychotic more than the first generation. Device malfunction is suspected but no established recurrent harm. Go through the device engineering. If the newly introduced medical device causes repeated serious harm due to design related human factors problem and a safer alternative exists, immediately discontinue that device. Minor epistaxis plus dry mucosa plus normal labs. The most important causative factor is dry or arid climate, severe hypertension plus acute end organ damage. This classically indicates hypertensive emergency. Abruptio placenta, this leads to uteroplacental insufficiency, and this leads to late deceleration, and this leads to fetal distress. Even though heart rate is mentioned in the range of 110 to 160, but you still have to go through the do this C-section, emergency C-section. Contrast reflects into the ureter and renal pelvis. This is classic for VUR. Concerning behavior outside work, repetitive substance abuse but no workplace impairment. As a co-resident, what should you do? Discuss the concerns with the program director for early supportive intervention. Do not treat an anticipated symptom before understanding the patient's concern. Patient expresses multiple concerns, explore first, then provide targeted therapy. In a wrestler or boxer, trauma plus fluctuant swollen pinna, immediately drain the auricular hematoma and apply compression. Buccal fracture or torus fracture, you need to do cast immobilization. If the p-value is more than 0.05, the observed differences may be due to chance, so no significant treatment benefit can be concluded. Balancing measure, did the intervention create another unintended problem? For example, like a hypoglycemia in this case. Excuse me. Okay, let's continue. Persistent heavy bleeding with a dilated cervix after spontaneous abortion. This is classic for retained product of conception, and it requires an urgent uterine evacuation with D&C, even if the patient age is 17 years. In a non-verbal hospice patient, having brow furrowing, restless repositioning, and distressed vocalization and signs of pain, it should be treated promptly with opioids. In this case, the physician should promptly advise the son to administer sublingual morphine. Spiritual advisor, and spiritual or existential distress after the physical symptoms are initially addressed. New hypertension after starting an estrogen containing contraceptive, even if it is a contraceptive ring, discontinue the contraceptive before initiating antihypertensive medication. Hard pellet like stools plus stool withholding behavior plus blood streaking on the outside of stool, consider functional constipation causing an anal fissure. Mecal diverticulum, painless maroon or bright red rectal bleeding in an otherwise well child. Weeks to months after kidney transplant, fever plus graft tenderness plus acute rise in creatinine strongly indicates acute transplant rejection, versus CMV have usually 1 to 6 months after transplant, fever, malaise, leukopenia, pneumonitis, diarrhea. Persistent dermatomal pain with allodynia after herpes zoster. It is classic for post-herpetic neuralgia. Zoster vaccination is prevention, whereas amitriptyline gabapentin is treatment. Endometriosis, it classically presents with cyclic pelvic pain, dysmenorrhea, dyspareunia, dyschezia, infertility. Pre-gestational diabetes mellitus, the infants are at risk of congenital heart disease like VSD, TGA, conotruncal abnormalities, neural tube defects, caudal regression syndrome, whereas the gestational diabetic infants are at risk of shoulder dystocia, macrosomia, neonatal polycythemia, hypoglycemia, and RDS. Young sexually active female is at risk of chlamydia and gonorrhea. Do urinate. Whenever a gynecological surgery question asks about the ureteral injury, think of uterine artery and a ureter relationship. There is a famous mnemonic in the first aid, water under bridge. Trauma plus hypotension plus unilateral breath sounds. This classically indicates tension pneumothorax. Do immediate needle decompression at the fifth intercostal space in the mid-axillary line, followed by chest tube placement. Do not wait for imaging. Don't even do fast here. A fast is an important step in the evaluation of hemodynamically unstable trauma patient, as it allows for the diagnosis of intra-abdominal hemorrhage and pericardial effusion or tamponade. It is not used for tension pneumothorax. Non-smoker plus central endobronchial well differentiated mass, go for surgical resection. This is a classic case of bronchial carcinoid. Patient has capacity plus no immediate emergency and refuses intervention. Just respect the autonomy. Flail chest requires more than 3 consecutive ribs fractured at more than 2 sites, causing paradoxical chest wall movement. Rib fractures alone cannot be used for flail chest diagnosis. High speed collision plus steering wheel chest impact plus hypotension plus new ECG abnormalities. Think of blunt cardiac injury, a cardiac contusion, or a structural injury. If the length of intestine is less than 180 centimeter to 200 centimeter, it is a classic for short bowel syndrome. Length of intestine is around usually 600 centimeter. Resection of 10 centimeter doesn't cause short bowel syndrome. Orthostatic hypotension is commonly encountered in the post-op period and is primarily due to hypovolemia. Peri-op fluid status should be closely monitored. Anaphylaxis, epinephrine is usually given IM. Subcutaneous can also be given if it is in the options. Strongest risk factor for PAD is smoking. Regular aerobic exercise plays an important role in prevention of dementia, Alzheimer's, and would likely improve this patient's future outcomes if recommended. Reactive attachment disorder, child is withdrawn, whereas disinhibited social engagement disorder, child is overly friendly with the strangers. Suppurative parotitis, most commonly caused by Staph aureus. Nightmare disorder, the treatment is imagery, rehearsal therapy, and prazosin. Atopic dermatitis can involve cheeks and diaper area. Ovarian torsion, immediate management is detorsion or untwisting. Thyroid nodules are hypoechoic and greater than 1.5 centimeter should undergo FNAC to rule out malignancy. Patients of hepatitis C infection should undergo counseling for many lifestyle changes such as weight loss, smoking cessation, and alcohol cessation. Patients of hepatitis C should undergo hepatitis A and B vaccination. If concomitant liver disease is present, pneumococcal vaccination too. CA-125 is used to monitor recurrence of ovarian malignancy. PEP for HIV should be provided in less than 72 hours. It is futile to give post-exposure prophylaxis after 72 hours of exposure. Most common complication of blood transfusion is febrile non-hemolytic transfusion reaction. Migraine is a clinical diagnosis. It's not no labs are involved. Acute chest syndrome, the diagnosis is acute chest X-ray. AFib patient undergoing ablation procedure, do a transesophageal echo to look for atrial thrombus. Acetaminophen toxicity can cause central lobular necrosis. Prostate cancer, bony mets. This leads to increased ALP. With this, we finish the NBME 16 review. Thank you.